When it gets to 0, it means we start.
The final countdown.
The final countdown.
Where'd it go? It's like 94 and 90, and it disappeared.
Your screen might be upside down. I think it started at 6.
Oh, really?
Is he your brother?
Yes.
Yeah,
Whether he wants to admit it or not.
Yeah.
Poor brother.
All right, so here's how the order is going to go. We're going to do our normal intro for the Doc Doc Goose cast. We're going to do our disclaimer, and then we'll intro Dr. McAlister and talk about the topic that we're going to be discussing, and then we'll get into it. For discussion, so Ben, you looked over the questions, and I sent them to Dr. McAlister as well.
Yep.
Heels. Oh, I thought you were just going to put wearing heels, especially guys in heels. I can see you editing the document while we're going.
Oh, yeah.
So another topic, Ben, that I was talking to Dr. McAlister about was just kind of choosing footwear in general.
Oh, yeah.
Because that's something that I've always led patients through. I'm curious what his viewpoints are, especially like I would sit there and watch like at Roadrunner and all their spiel about shoes and footwear, and I think that it's all BS what they would do with people, but just how do you pick the right footwear for you and who you trust? Mm-hmm. If you can answer the who do you trust question at all, because if they're trying to sell you something, you don't trust them. So there we go, and then we'll do all of our stuff afterwards. After we do the discussion, then I'll talk about like where they can follow you and your practice at the end. Then we'll let you jump off. We'll finish with our sponsors and stuff, and then we'll be done. So you can end a little bit earlier than we do.
Oh, man.
All right. Here we go. Hello and welcome to another episode of the Doc Doc Goose Podcast. My name is Sean Palmer. I am one of your docs. Here with us is Ben Imes. He is your other doc.
I am Ben Imes, and I'm still a doctor.
Are you still a physician?
Ooh, also a physician. Ah, man, it's been a while since we've done these intros. I forgot what I'm supposed to say.
Got to get back on the horse. And our goose, he's reluctant to come back, but here he is, Matt Imes.
Still here.
Welcome. Ben, let's do the disclaimer before we get into anything else.
Before we introduce our esteemed guest for today, that's fine. So our disclaimer for today is that this is an educational podcast. We are in no way attempting to establish a patient-physician, patient-PT, client-architect, podiatry foot owner relationship with you or any of your friends who may be listening with you. This is purely for education and maybe a little bit of entertainment. Also, the views that are expressed on here do not represent those of our companies or really anybody else except for the voices that you hear on here today. Does that about cover everything?
I'm impressed. It's been 3 months since you did that, and you just rattled it right through like we've always done it.
Boom. I do that before our lectures that I do with the residents. I provide them that disclaimer every single time. So,
I'm glad you're still getting practice.
Yeah, it's good. Yeah.
We haven't done this in so long that I was concerned we were going to forget how to do it. But we can talk into a computer, so it works.
Here we go.
On today's episode, we have a special guest on. We have Dr. Jeff McAlister. He is a podiatrist. Dr. McAlister is a board-certified foot and ankle surgeon who specializes in advanced foot and ankle construction. He has offices in both Scottsdale and Phoenix, Arizona. He got his bachelor's from Iowa. He got his DPM from Temple University School of Podiatric Medicine. Dr. McAlister has completed a rigorous residency training in the Northern Virginia suburbs through the Innova Fairfax Hospital Podiatric Residency Program.
Probably should have practiced this before you started.
Man,
but carry on. You're doing a great job.
Yeah, I dream of having a resume that long. That's amazing.
Don't worry, there's actually still more. I just interrupted.
Oh, gosh. Intermission.
Sorry.
Hey, unless you want to edit this episode, shut up. Oh, where was I? I think I was on 3. He completed a rigorous residency training in the Northern Virginia suburbs through the Inova Fairfax Hospital Podiatric Residency Program, where he specialized in foot and ankle trauma, adult and pediatric reconstruction, and diabetic limb salvage. Dr. McAlister is also one of the few podiatric surgeons in the United States that has completed a 12-month surgical fellowship at the prestigious Orthopedic Foot and Ankle Center in Columbus, Ohio. All that to say, he knows his stuff. Welcome,
Wow.
Dr. McAlister.
Thanks, guys.
Yeah, we're glad to have
Appreciate
you.
it.
Thanks for joining us.
This is awesome.
So just like you would normally do when you have a podiatrist on, our topic today is concussions.
Right.
So full
Boom.
concussion protocol,
I'm out.
return to sports.
Literally.
About right.
Yeah.
So are we, I think.
Yeah.
I'll stay in. I'm not an expert on anything, so nothing.
You've hit your
new.
head a couple times,
Yeah,
so this may
exactly.
actually be relevant. Yeah.
Fun fact, I've had a concussion that hospitalized me, so I can speak from
Nice.
experience. Let's do
Nice.
this. That explains a lot of things I'm told nowadays.
Actually, I think we're talking about feet today. Isn't that right?
That would be what podiatric medicine is.
Boom.
Boom. So Dr. McAlister owns, like I said, Phoenix Foot and Ankle Institute here in Phoenix. You have 2 locations,
Yeah,
correct?
so we have landed in Old Town, and that's where we hail from right now. We also have a North Phoenix office just off 17 and 303 for our Anthem friends and Prescott friends. And so easy to get to in the north side. But yeah, we are laying ground in Old Town and paving our way to a couple more offices, hopefully in Goodyear and Chandler over the next 2 years. Got to grow.
That's awesome.
And hopefully another associate and things next year. So things are blooming, Sean.
That's awesome. Congrats.
Congratulations on that. That's fantastic.
And you guys didn't start that long ago either.
So, Jeff, when you say things are blooming, you mean people are getting injured more?
People are starting to get off their couch and go outside. And
I got you.
Exactly.
We were talking about that actually a little bit before the show started. That that you might be seeing a little bit of a resurgence of folks who maybe didn't do a whole lot over COVID, and now they're figuring out that that their feet are not as reliable as they were hoping they would be.
People are tripping over their own feet, probably, I guess you could say. And so the couch potatoes are starting to turn into mashed potatoes, I guess. And so we've seen a bunch of Achilles ruptures, and it actually has helped, believe it or not, with business, if you will, with people that do work from home, because they're able to recover so much faster, so much easier, because they can just work from home. And so the burden of trying to go back to work sooner after a flat foot surgery or a bunion doesn't exist. So it really actually streamlines the post-op process a lot. Yeah,
That's great.
Glass
I didn't think about that
half full,
part.
Exactly.
So as we talked about today, we're going to talk about all things feet. And I think the most common stuff that I'd always wrestle through with patients is how to choose footwear, how to choose insoles, and if insoles are needed. Along with that also is your custom insoles. Not just insoles, but orthotics. And so Ben and I hung out this weekend. We purposefully did not tell each other our theories on these topics, just because we wanted to hit from the standpoint of, we don't know what you think. I don't know what Ben thinks. He doesn't know what I think about these. So we're going to have a fun discussion about this. So I'm going to start with a really open-ended question of, what do you think about the use of insoles and custom orthotics today?
To me, custom orthotics and insoles, I would classify as orthotics being typically I try to train my patients into thinking that orthotics are custom, insoles are over the counter, just so they can kind of differentiate the kind of bread and butter versus what we have to offer in the clinic. Generally speaking, I tell anybody this, whether it's a post-surgical patient, and we can kind of break that up into like recovery type of orthotics versus someone that's just coming in for foot pain, generally speaking. But I think they're for comfort. The research has been shown that a lot of orthotics in general and insoles are for comfort only. So that is just a plain statement, and we can get into some more things, specific to diabetics and plantar fasciitis and all these different diagnoses. But generally speaking, I think they are for comfort, and whether it be a long distance runner or Grandma Jane that just kind of walks the neighborhood.
So, just coming from a primary care standpoint, I had 2 plantar fasciitis patients today.
Thanks for the referral.
One was very, yeah, exactly. And one of them was very on top of it and had done a lot of that good early treatment stuff. Trying some stretches, trying to take your anti-inflammatories. As far as insoles versus orthotics, do you recommend that folks do insoles first, that over-the-counter stuff you can buy off a shelf first, and then if that's not working, then they're going to come see you?
Awesome. So
how do
if
you
I was
approach
in your office marketing my practice to you, and I said, hey, why don't you try this stuff before you send them my way? What I would do is tell them to try I'm economical, the hospital, the healthcare burden is real. I would tell people and anyone, try a nice pair of, and I'll recommend some, over-the-counter insoles, see how you do. If that works, great. You can keep doing that with the same brand. They're $50. You can buy 2 a year or whatever. If it doesn't work, then we can up the ante and get custom orthotics with a special little heel pad and kind of full length, and really kind of delve into some intricacies of a specific orthotic that we'll talk about. But I think and we may be even missing the boat with diagnosis at that point if it didn't work with the regular over-the-counter insoles. So plantar fasciitis in general it's been shown it's like hit or miss, 50-50 with insoles and plantar fasciitis. Which is probably an hour-long conversation about the treatment of plantar fasciitis, and we can throw a lot of things against the wall and not really even hit the target. But I think in general, the purpose, again, can be comfort, which would include supporting. I call it like supporting the plantar fascia like a bra. Kind of makes sense with half of the population typically, and that supports the plantar fascia when you're in a shoe, and versus being barefoot. So that's the purpose in that situation of an insole, which doesn't necessarily have to be custom, because everybody's weight. I think that comes into plantar fasciitis specifically. The patient's weight. They could be severely overweight, and insole won't make a difference. It's just not strong enough. So,
That's a good point.
Yeah. So
Do you have a favorite brand of insoles?
I was thinking about this. I typically recommend things, and there's something I would recommend in the office, which is typically Superfeet. I think they're kind of a go-to brand. You can buy them anywhere. I do have some in the office that you can't find in Amazon. So as a private practitioner, I don't want my patients to be able to go find something on Amazon, because that's not helpful per se. But a good quality insole, I typically like full-length insoles to support the forefoot, really just for cushion. Superfeet has a wide breadth of kind of thicknesses and opportunities for patients with kind of a slightly flatter foot or a slightly more arched foot, and they come in fun colors. But there's a million different types of brands. The manufacturing business knows that this is one of the most popular musculoskeletal diagnoses out there in my small world below the knee, next to a bunion. And so there's money to be made in over-the-counter insoles for sure. But the average range being from 50 to 70, as you know. And I think that the problem really is not necessarily the brand. It's whether that guy in the shoe store should be selling the insole with that type of specific shoe. How do they marry that relationship when a patient goes into a running store? How are they, or a shoe store or whatever, how are they able to say, hey, this shoe in particular over here, that's probably where we were going next, Sean, but how can we get a perfect match for that patient's foot and not necessarily sell them an insole no matter which shoe they get? So
yeah, and there's some stores that are just I'm going to use the word kind of criminal about it, that I've sat there and watched them. They go through this huge process of running on a treadmill and stand on pressure plates and let's custom mold this. And oh, here you go. You didn't even know it, but your insoles are already custom molded to your foot. Now we're going to give this associate. They're going to go pick a $200 shoe off the wall for you. And it's just horrible. And their process is so good and ironed out, though. I'm not going to say the name of the company because they'll get in trouble for that. But their process is so ironed out that people believe that what they got was a true like custom insole. It's great. And I'll take them out of the shoes and make them stand on it and say, here, let me take a picture for you. That thing flattened out like a pancake. It didn't do anything, but it's hidden in the shoe and you didn't see that. But hey, you just paid $80 for a
especially if they
piece
didn't
of
even
foam.
have
So
like
congratulations.
foot pain necessarily. They were just coming in for new shoes, you know?
Right?
Yeah.
Right? Exactly. And I'm like you. I love Superfeet.
Yeah.
That's what I've always sent patients for. They've really done a good job of making those. So what? I agree with you that you start with the easy, like the insoles, progress to custom orthotics, and that line can just change with every patient to when you hit that point to
It's
where
the bag of shoes
you
patient.
you
They
think
come
you
in
need
literally with a bag of orthotics and a bag of shoes. They've been to 10 different people and they were smart enough to buy 10 different pairs of cash pay orthotics. It's that patient that you're like, this isn't working. Sorry, go ahead.
Yeah, exactly. What things, what conditions like would jump a custom orthotic to the front of the line? Say, okay, we have to go to this first. Like, what are conditions that would necessitate that?
Require more correction would be more that supinated foot, hind foot supinated foot, where you need a specific deep heel cup. I mean, I am like literally writing 5 lines on the prescription that you can't just buy on Amazon. You can't buy some tin little patty pad thing to put in your shoe to help work. It's the guy that kind of walks on the side of their ankles and they are 80 and can't get an ankle replacement or some big procedure. And then so when the foot tips out and tips in, so the nice flexible flat foot and the patient that has more of a supinated foot, like significantly supinated, that requires specific instructions. The only one is probably leaning more towards like neuroma type stuff. And so the metatarsal pad thing and the forefoot cushioning, you can't buy a shoe that helps that typically. And that it's hard for us to guide patients on how to put on their underwear, for instance, where to put this pad in there. I'm sitting there describing where to put a pad on their insole for like 5 minutes. And sometimes having the orthotic already made, it's already in the orthotic, and it's a lot more streamlined of a process. So, and that's like with taking business out of it and all that stuff, just straight up clinical conversation, and the reality of what happens on a day-to-day basis. So,
yeah. How long should a custom orthotic last? Is there like a window that should last in?
I like that question. I get asked that all the time. I like that question.
I would say I have seen orthotics that are probably 3/4 length. The hard ones, the like leather ones that they've probably were made in the like late 90s, I would say. I've seen some 30-year-old orthotics before. I tell people 10 to 15 years, to be honest with you. I mean, if they're well made and they're like plastic and not the foamy, filled instep ones that you might get in a physical therapy office, maybe, but not the hard plastic ones, then usually I would say at least 10 years. Oh, you're a PT? I'm sorry.
He just called you out, dude.
Hey, everyone is safe. I have never made an orthotic in my life, nor will I.
I forget. That's a very good. I like that distinction between orthotic and insole. What about insoles? How long should an insole last?
The amount of miles you're putting on it. I would say 6 months max. Yeah.
Okay.
Yeah.
That's generally how I go. But yeah, exactly. I mean, if somebody's not wearing their shoes and they're just a couch potato all day long,
Yeah,
that insole could last
there's
them
kind of
forever.
a situation where
it's never being used.
there's the I call it the long-term play, which is the custom orthotic with a person that has a flat foot that we're trying to prevent surgery, and they've done some PT, they have strengthened their post tib. We just need to keep them in that position. So it's kind of like my AFO type of device. And then there's the run-of-the-mill, hey, I have some foot pain, okay, plantar fasciitis, we're treating something. So there's the short-term game, which is probably the economic over the insole, see how you do. And then the long-term play, maybe it's a kid that has gotten over severs, they have a mild flat foot, and now they need something more rigid to help hold up their navicular, and that usually is the UCBL, or the short little orthotic that goes in a kid's shoe. So corrective is probably a nicer word for it.
How often do you see someone that comes in with those old orthotics that they've had for a decade or two, and they just do not? Their foot structure has changed to where that thing is not doing its
Not
job
very often.
anymore. But they're still.
And I'm not calling
orthotics
orthotics Invisalign by any means, but patients, people get used to them. Your foot, typically, if they caught it early enough and they weren't in their 50s when they got them, then they wear, again, the whole, back to the circling back, if I could say that, circling back, they are for comfort. And so
you and Jen Psaki.
A patient has gotten used to them. They bring them in because maybe they don't know it, but maybe something has slightly changed, their navicular has dropped a little bit or something. But for the most part, they take them out of their shoe. Are these okay, doc? And oh, by the way, my bunion, something that doesn't even get corrected with an orthotic, my bunion hurts. It's no, I wouldn't even. They are hard as a rock. I can't push down on them at all. They're super strong. Typically, they're leather. The leather's all beat up and stuff, like a old hat or something. And it's nope, don't touch them. Maybe resole them or something, or recover them or not, whatever. But typically, no. I would say that they wouldn't last a custom orthotic if their foot changed shape more than a year or two. I mean, they would not come in 20 years, 15 years, or whatever down the road with an orthotic that's lasted that long and something significant has happened. It's probably not even the problem. They come in just kind of, let's just say for toenails or some completely unrelated thing, and they're like, oh, by the way, I've been wearing these, and are they okay? It's yeah, I'm not going to just pull your couple $100 because I think that they're ugly, Yeah.
Now, I want to jump on that real quick because what are you doing to make orthotics look beautiful? My mother-in-law calls them dorkthotics. I'm calling her out right now.
Most of the time,
what are you doing to make them look
the
good?
Anatomy of the orthotic. The top cover can be interchanged with different. The basic prescription that I fill out has black, blue, lavender, or pink, swirl or no swirl. And so that's step number one, right? And so it's nice. A kind of polypropylene, kind of a soft little cushy top. And right. And then there are some companies that are getting into the custom game. There's a brand called Remind Insoles or something, kind of like a skater brand. So they have the kind of Mexican skull thing. They have all these fancy little designs. A lot of patients don't give a because they're inside the shoe. But it's kind of a thing. I have on my in-office dispensed insoles, I would call them. That I have my logo on them. I mean, that's as sexy as it gets, So, but if I had to be part of that game, I would have something that they could interchange. I think that would be kind of fun. Kind of like how the Crocs have the little things that you can put in the holes. Very, very similar. Yeah. You can kind of doll it up a little bit. But the overall arching problem is that often, which is the reason why people forget about me until something really is falling off or hurting, is because you can hide your feet in orthotics and shoes. So, yep.
Right.
Do you ever see
Right.
orthotics being overprescribed, even from a certain specialty? Like
Physical
you just
therapists.
You just ragged on physical therapists, so I'm going to
Yeah,
throw that
I'm
one.
going to call them out right now. Those
I
guys
don't like.
all the time.
Okay, so one would be podiatrists. Obviously, I think that is often looked at as an easy opportunity, if you will, and I think that not every plantar fasciitis deserves orthotics. I think there's tiered algorithms for this. I start with the insoles. If it doesn't work, a custom's not going to work. So why am I going to try this thing? Typically, if that's the problem, plantar fasciitis, and then or they just don't want to buy them every 6 months. That's kind of the other conversation. So the what else? So DPM's number one. Number two, I kind of think more like is Sean on here? No.
Say it.
It's it's either a PT or even a hip and knee guy. It's kind of like someone that, hey, my knee's doing great. It's your foot problem. Go see the foot guy for some orthotics. And I see him. I'm like, dude, they were genuvarum 30 degrees, and now their foot's inverted, and they or they just don't need them. They just are trying to shoo the patient away. So that's kind of a little zebra for you, but I think that is out there. Back to the PT thing. It's overprescribed is a little aggressive. I would say over discussed maybe, or it's probably more of a business decision. I think more than anything. I don't know if it's necessary all the time, but yes, back to the original comment that orthotics are for comfort most of the time, 85% of the time, and if someone's complaining about something, it's a very easy thing to say, like, oh, you probably just need some orthotics. It's a very simple like catchphrase that people bite onto really quickly, and that's why there's a business behind it. So I have a hard time selling them, to be brutally honest with you. I have a hard time pushing them sometimes because it's hard to sell something when you don't necessarily believe that it's a fix for everything. It's not Windex. Or duct tape.
And they're so expensive. Are you great?
Or duct tape.
Windex fixes everything.
Right.
What makes them so
hands,
expensive?
man.
It's like $900
so let's talk about
for a pair of orthotics.
Let's talk about cost and then like how they're made in the office. Like
the
how
magic
do I
that goes
get
into
from
it.
point A to point B? Because I think that's important when we talk about this. So cost to me is market value. I mean, they're my friends in New York, $1,000, period. Yep. And so from point A to, and around here, they're about $5,000. Why are they so expensive? Because the next guy sells them for $450. And insurance, privates pay $550 for customs, which drives the cash price. So, and that's for a pair, obviously. So from point A to point B, the idea, as you know, Sean, because you sell a lot of orthotics, the idea behind this is to capture a patient either weight bearing or non-weight bearing, right? And so your foot arch changes when you stand, right? So there are some guys that use lasers, lots of lasers, and they'll do an iPad. They'll hold the iPad up to the foot. You've probably seen it online. It scans the foot. Jesus. And so, sorry, get out of here. And other guys will do foam boxes. So they'll put the foot in the foam box. The foam boxes cost about $8. And that you have to buy 50 at a time. There's an inventory game. You have to send the box to a guy. The guy comes and picks it up. It's very old school, but it works. And that's non-weight bearing. That's just them sitting in a chair, pushing down into the foam box. It feels like a nice massage. But then you can capture and kind of put the foot where you want it. How I was trained was maybe how Sean was 20 years ago. And it was with mold, like plaster. So the patient's non-weight bearing, typically laying on their belly, and you can like dial in the foot and put it like right where you want it, and mold the foot. It gets the office all dirty. Usually there's a specific room for it. It takes 20 minutes to do because it's plaster and it has to dry, obviously. And then there are the last way is the Dr. Scholl way of standing on a pressure mat looking thing, and the other issue with that is that you're going to make the orthotic as flat as their foot is standing. So if you're really trying to correct something, then you need to almost have the foot more, especially a flat foot, then the foot needs to be more in a supinated type position or arched position so that you're correcting something.
Not to get off subject,
Awesome.
but that word came up again.
So
What
supinated
does
typically
supinated
means like
mean?
high arched or outward rolling of the foot. And so the pronation obviously is the other way. So that technically would be like a flat foot. So that's pronation or eversion, and inversion is where the foot rolls out. That kind of lends a person to have a high arch, and that's where you'd step on the sand and you'd only see like the outside of your foot and then your toes. So yeah, usually a person with a supinated foot has more pain like on the outside little bump or fifth metatarsal base of your foot, or their fifth toe region and in that part of the foot there. Which is usually very hard to accommodate for, because the outside of the foot's just very bony, and when it hits the side of the shoe or the side of the ground, it doesn't bounce back very well. Like the arch is more springy, and it just has a lot more cushion and meat on the medial side of the foot. And people can live with a flat foot, not doing anything, no orthotics, no nothing. I have a pretty flat foot, and I don't have any pain. It won't hurt for many, many years with or without orthotics. It'll last way longer than a person with a more supinated foot that kind of walks on the side of their foot. That is a very good question.
Matt, that was a great question. I'm glad we have you here today. If nothing else, for that one question.
Oh, there's more. Don't worry.
Oh no.
Oh, no.
Go ahead.
Hey, I want to, Sean, I don't know what else you want to hit, but I really want to hit on heel spurs real quick.
Go for it.
Man, this is like, I don't know, Dr. McAlister, maybe this is where you've got a very strong opinion. The podiatrists I've trained with, they were kind of wishy-washy on this, that, sometimes the heel spur causes plantar fasciitis or foot pain. Sometimes it's chronic pain leads to a heel spur.
Good question.
What are your thoughts?
So
how badly do we need
in,
surgery to get rid of these
okay,
things?
Maybe half the time, a patient with heel pain, when I see them on the schedule, they have maybe done an x-ray, they saw you, maybe that you ordered an MRI, maybe, and they were told they needed surgery. Oftentimes they went to an not by you, but it's the general concept is that they went to an urgent care because their foot hurt Friday afternoon and my office was closed. They wanted something immediately, went to urgent care, and they told them, hey, you had a bone spur, you got to go to the doc and get surgery. And that's a common cliff I have to walk them off of, because it is often misconstrued as an emergent case that we have to take them and do some open heart surgery. So the general concept in my mind, my pea brain size mind, is that that the heel spur is a result of traction, basically is a good word for it, on that ligament on the bottom of the foot. And as that traction or pulling of the ligament on the heel bone, it tears, it bleeds, it forms bone. That happens with many steps over years. It's not something that just built up yesterday. And sometimes they can break in kind of odd zebras, but for the most part, that heel spur has built up over time. There may be a little bit of bone marrow edema kind of in there if you got an MRI kind of acutely, which is not indicated, but it's really the ligament that attaches almost right below that or with that heel spur there, and the ligament is pulling. So it's not something we typically chase. A lot of, like how I was trained basically, is it's a radiographic kind of appeasement basically when you are actually cutting off the spur, because it's like a patient fixates themselves on the spur, and if the spur's not gone, then it's not better. And that's something that literally I'm like in the OR taking it off. I'm like this. I'm cutting the ligament too, which is the main part of the procedure, but just taking off the spur is not something that is going to change. So they've studied this obviously in patients they just had a plantar fasciotomy, which is a surgery for the like long-standing over a year plantar fasciitis, and then just taking out the heel spur, and the patients with just EPF or just plantar fasciotomy did better. They've also studied patients that came into the clinic. They just asked them all after they took x-rays whether they had heel pain. Half the people had a spur and half the people didn't. So those kind of studies tell us that it's not always like clinically relevant radiographically whether they have a spur or not. Yes, I still take x-rays to check on everything, but for the most part, it's the plantar fascia that gets inflamed at the insertion onto the heel bone. Yeah.
Well said.
I really like that answer. Thanks.
Yeah.
It's one of those things that I've been trying to convince my patients for a long time, but again, half the time I still send them to podiatry, and I feel bad about it. I'm like, look, I know you've got a heel spur. I don't think that's what's causing the problem, but why don't you go talk to the podiatrist and see if he or she wants to do something about it. I appreciate you and all the other podiatrists who've had to deal with.
What is your if you see a patient that's been dealing with it for
downstream
a month or
effects?
something, what have you been taught as your first line treatment for it? Yeah.
For plantar fasciitis? So I think that's a very fair question. And again, that's something I gave this speech twice today, which doesn't always happen.
Wow.
And
what are the odds?
I know, right? So I tell them, hey, first of all, you need to be wearing shoes. So you can't be walking around on your hard tile floors all the time, or in heels. I don't know if heels have anything to do with it, but hard tile floors. You need to be doing some stretches. I tell them, I usually have them do about, if their kidneys can tolerate it, about a week or two of scheduled anti-inflammatories. And then I have them roll a frozen water bottle along that arch. So I have them freeze their Dasani or Aquafina water bottle and just roll that on there at least once a day. And
you don't suggest the Fiji water bottle, that square water bottle? That's not going to help.
the square water bottle works sometimes. Yeah. Those are ones, when I'm working over at our Scottsdale clinic, I'm like, try the Fiji. Yeah. And then I also talk to them about getting insoles. I tell them, hey, just go find something at Walmart, Walgreens, CVS. At this point, they've got shoes that are 400 years old. And the big thing that I tell my patients, and again, please correct me if I'm wrong, is a lot of them, they'll buy these insoles and they'll just sit them right on top of their shoe and they won't pull out the old insole. And so I have to go through and show them, hey, you've got this little insert in your shoe. It's not glued down right. It's really easy to pull out, but most people don't ever try it. You pull out the old one and put in the new one. And that's usually pretty shocking to a lot of my patients. And I'd say that's probably my general approach. And then if they still come back, all these things, then I talk to them about, hey, I can do an injection or I can send you off to podiatry.
Yes.
You get an A- for your answer. I'm looking for the words PT.
Okay.
Ooh,
PT was
I'll tell you,
missing from your answer.
I have never once referred somebody to PT for their plantar fasciitis. Not physical therapy in general, but for their plantar fasciitis. Man, you guys get my back pain, you get my hand pain, you get my shoulder pain, you get all that stuff.
Okay,
but plantar fascia, PT,
So
I don't know. I've
I'll
never
let
done
Sean
it.
talk in a second. Yeah. So
Maybe that's something I just need to start doing.
Standard. That's a good approach. And I like
Get him,
everything
Jeff.
you said.
Get him.
My kind of standard speech is I need to fill 3 buckets or 3 priorities in this treatment. One is support. Insole, here you go. You're not wearing anything, or they show up in the Arizona flip-flops or whatever. Okay, let's wear either good support or some kind of insole, something in your shoe. It's kind of the avoiding barefoot conversation.
Yeah.
That's the bra. That's the holding up the ligament. That's avoiding barefoot, the whole concept. Next is the functional side of this, which is the PT. So they get typically a night splint. That's in-office dispensing, obviously. And then PT to help with accountability, number 1. Number 2 is the cupping and the dry needling and all the stuff that Sean can talk about. And then, so it's the active treatment part of it. And then the anti-inflammatory bucket is basically what you said, plus or minus a shot. And then I throw in other, which is PRP, stem cell-y kind of stuff, the amnio thing, and shockwave, and the other cash pay stuff. Usually I start with the kind of cost containment centers and then work from there. But I would say PT, some type of shot, and some type of good shoe. And my shoe talk typically is a neutral shoe with an insole or a stability shoe. And so there's two different types of shoes, obviously, as you guys know, and go from there.
Okay.
Oh.
And I before we let Sean talk, I want to talk shots. I want to talk shots real quick. I usually tell patients when I inject them, it's usually with a little bit of a small steroid, so a triamcinolone, and then a little bit of like a lidocaine or marcaine. I typically tell them it's one of the most painful shots that I do. I inject a lot of things, and I typically will use like a 27 gauge needle, so a pretty small caliber needle there, but typically that's where my patients really feel it. Has that been true for you? And do you use something different? Should I be using something different?
Kind of guy. And most DPMs want to see someone back every week. I don't function that way. I'm not an E&M kind of guy. And I think that it's healthy to treat people in an economic manner, and a lot of it's PT, which I can kind of put it on them to do. And if they don't do the PT, like this lady I saw today, they did a shot under ultrasound. I hit it perfect, bullseye, 25 gauge, 1.5 inch. I do a 2-to-1, just lidocaine plain, 1%, and Kinalog 40, and that's it. Usually rock solid, usually medial, tubercle, that whole thing. And then I do it deep to the plantar fascia so it doesn't disintegrate the fat pad. So that's why I use the ultrasound. Yeah.
100%. Yeah.
Sean?
Yeah. It seems like I'm really missing the boat on physical therapy, though.
That's why we're friends.
Oh, shoot. Buddy, I'm sorry. I didn't know you guys even knew about feet.
You know, I hear Dr. McAlister believes in it so much it might actually find its way into his clinic one day. Obviously, I'm biased. What do I say?
Really?
Yeah, we treat plantar fascia all the time.
Because
this is brand new information to me.
Talk about the kind of
I had no idea.
Some of the root causes. I mean, we're getting dialed into plantar fasciitis right here. But what are some of those root causes of plantar fasciitis that make it come back all the time?
Yeah, so you guys talk about you guys have hit the causes that go from the calcaneus or the heel forward, right? I'm going to take the cause from the calcaneus backward up the back of the leg. So you're really looking at, we very commonly see calf tightness, and pretty significant calf tightness. You can tell one side to another, right? So your typical dorsiflexion should be 5 to 10 degrees within your normal ranges, and you might usually have a patient that will sit like maybe 10 degrees on their unaffected side, and they're 0 on their affected side. And it's something you wouldn't ever know, because passively, like when they walk, you might not pick that up as much because the weight of their body bringing them into the passive dorsiflexion, you're not going to catch it that way. But if I get them on the table and actively have them do it, there's a big difference. With that pressure pulling back around that calcaneus, pulling it up just a little bit, that's going to be enough to cause those issues. You can also, we differentiate between the plantar fasciitis or irritation of that nerve that goes through there. And there's several patients that I send to podiatry because of that. I get to a point where I say it's not the plantar fascia. Like, we've treated enough, we've normalized all your motion. It's not that. I really think it's nerve root irritation. I forget which nerve that is now. It goes through it. I've been practicing for 3 months, so I just don't know anything by this point. There you go. Sometimes you just find out, like, it's just like that. It started as plantar fasciitis. You had inflammation sitting along that area for long enough that it irritated that nerve, and it can't find its baseline again. It's not going to settle back down, and then it needs that special intervention to get it back to where it should be. I do a lot. So I am very manually based as a physical therapist. I don't believe that if you're going to a PT that just does exercise, I don't really know why they went to school and got their doctorate. That's insane to me. So I think you have to have a manual therapy approach on people. So we do a lot of stuff, whether it's dry needling or cupping or using other instruments to break up the adhesions along the plantar fascia. decrease the fascial tension along the backside of the leg. Sometimes even go up to the hamstring if it's even up that high. Of course, you're clearing the low back too, making sure you aren't getting any radicular pattern from lumbar spine. That's something that we're going to rule out for you. You're welcome. Really breaking up the gastrocnemius and
a lot of big words.
It's not tight and you have symmetrical ranges of motion.
I love it. Love the differential.
Sean,
I haven't lost anything. 3 months. There you go.
Wow. All right. I'm gonna add it to my tool bag from now on, Sean. I'm sorry.
And usually, like we're gonna send people for insoles. Hopefully, if no one else has gotten to them by that point, and send them to like Dr. McAlister said. I love super feet. That's what I've always sent my patients for. So hopefully, get that started as fast as possible if they haven't seen the correct person.
And
do
usually,
that
these patients don't require surgery.
If it's something that we can't get under control, then
the textbooks say about a year is the standard kind of treatment algorithm that we recommend. But lots of failed everything. I wouldn't even order an MRI for at least 6 months. Now, someone will punch you in the head before if they're still in a cam boot over 3 months or whatever. They're going to punch you in the head so they can order an MRI if they're still hurting at 6 months. But I would say generally these patients surprisingly, they do decently well with surgery. But because this is so common, our surgery centers would be filled with plantar fasciotomy patients, and it's typically just not worth it.
You brought up a little bit ago nighttime orthotics, and Ben had a question mark on that. What was your thought on that, Ben?
Yeah. So again, my only question is how often are you prescribing those nighttime orthotics for some of this foot pain?
First visit, I actually have a little, because I'm a foot guy, I have a little typed up here my exercises to do, and not something that I just kind of Googled, but it's branded and everything. So these are the 5 things that you do 5 times a day related to calf stretching and the very specific plantar fascia stretches. And then if they can't do it themselves, again, back to the accountability thing, it's like, okay, night splint and you're going to PT. And the night splint for me, again, kind of focuses on that Achilles. I typically tell them just to wear it about an hour or 2 a day for probably 3 weeks. And then kind of when I would see them back 3 or 4 weeks. And that gets them to avoid putting it in their dust or their trash can or whatever, because if they try to wear it 8 hours a night like they're supposed to, much like a night guard, you're going to throw it away. So ease into it is the point, and then add another hour after that, and then just keep going from there. Some people want to be a hero and try to go for gold, but usually it ends up on the on the floor. So yep. Here he is.
Oh, great. That's a great answer.
So, what's something? Yep, I'm back. What's something someone can do to prevent going to see you at your office besides wearing shoes? What it sounds like. Is it so? It's like stretching your feet every day helpful?
Yes.
So you're talking about the person that has heel pain, doesn't want to go see anyone, they're just Googling stuff. What do they have to pay attention to on
heel
Google?
Pain, just saying, hey,
good
30
point.
30
So
years down
we should
the road,
probably talk about
I
maybe
don't want to have
preferred
foot
brands
issues.
and why and
What
stuff.
do I
But
do?
I think the problem is I don't wear shoes a lot, so I have a hard time answering this. but we haven't talked about flip flops or anything.
So you can't push that.
I think
Did somebody bring that up? Maybe
I think the
Ben
big
did.
thing is to be aware.
Ben.
To be honest with you, because
it's
and not
common.
hide things for 6 months or 3 months, and because I've seen big and small, fat and wide, the whole bell curve have plantar fasciitis. There's no like one person that will get plantar fasciitis. There's the 14-year-old with Sievers that comes in. Or the 9-year-old. There's the person like yourself, a $180, 6 foot, come in with plantar fasciitis, and 1 foot for some reason doesn't, like, why? We don't know. I don't know. I wouldn't be talking to you right now. And so it just comes in all shapes and sizes, unfortunately. So I don't know if there's a way to prevent it per se, but I do think much like a dental checkup or something, maybe a once a year look around to make sure that everything is healthy at least would be probably my first answer. Yes, you can stretch every day and it may or may not prevent some things, but everybody has heel tightness and heel cord tightness. So I guess that's kind of the perfect answer that you're looking for without looking for it. But wearing good shoes, and that's kind of the next thing that we'll talk about, and then just stretching your Achilles could probably just generally prevent foot pain from the front part of the foot to the mid part of the foot to the back part of the foot. Good. So I think I love Hokas. I run in Hokas. I
What are your
triathlon
favorite brands for shoes?
I'm a Hoka guy. And they've kind of talking about the Maximalist, the really big, thick shoes, and then the Minimalist, the Vibram 5-finger shoes. I think they've gone from the Vibram style shoe where there's a different trend and they were headed that way, and then they realized that, wait a second, we're going too far. We got to swing our pendulum over here, and they went for the Maximalist side, just shoe brands in general. And I think really what we're finding is specifically Hoka that we're marrying this. They need to have every type of shoe, first of all, but the Hoka kind of has a nice cushion, lightweight, and different kind of ranges of height drop in the shoe. So Hoka's number one. Number two is Ultra, ALTRA, Ultras. They have kind of popped up real quick. They're probably number 5 or so in line of popularity in the country right now, I would say, in market share. Hoka's probably number 1 almost at this point, above Brooks and New Balance. Yeah, they are hot, really, really hot. And so Ultras they're flat.
Really?
They're kind of like, they've been known as the ultra marathon-y kind of shoe, but I would say, Ben, that it's a good recommendation for like a bunion, just a standard 30-year-old, 40-year-old lady that comes in with forefoot pain. It's a very quick answer because the toe box is real wide. It's very like caveman shaped and wide toe box area. And it allows for like that natural spread as we age. Our foot kind of expands like that. And so it's accommodative. We use that word a lot for diabetics and stuff, which we haven't talked about. But that shoe is really good. That's my number 2. And then number 3 is just New Balance because of the width patterns. They just have like C, triple C, D, F, whatever. They have specific stores just for New Balance. So they have a little bit more of a kind of like the other category, that like 70-year-old patient that comes in that needs a huge AFO brace thing that they have to fit like in a shoe, almost like a custom shoe that they can get like at the store at New Balance. So they're not typically a person that's going to be doing ultra marathons and things like that. They're going to be in New Balances, but they're a good run-of-the-mill household name as well. Oh, really? Oh, wow.
I've never heard of Hoka before, but I'm not
So
cool like you guys.
they went from
So
really, really
I'm looking
big,
them up right
and
now.
then
I'm looking at
people
Ultra. It
didn't
looks
like
like
the
they're
looks
very
of them
two
because they
different
look
styles
like
of
they're walking
shoes,
on,
which is kind of interesting to
pillow.
me. So
And then it kind of dropped the size from appearance. They're still pretty cushy in the back, but they've dropped it to more of like a normal, quote unquote, looking shoe.
Yeah.
But patients say that they feel like they're walking on pillows and clouds and all that terminology, but they're really nice.
I could never get used to. I don't know if they changed it, but like when they were first getting big, I would try to wear some Hokas, and it's like they have this like rocker bottom to them. You always feel like you're rocking through or being pushed through that motion. I don't know if they're still making them like that.
yeah, they do
the
kind of
rocker
look like
bottom
the
shoes are,
Skechers rockers.
They kind of come in and out of
is that
favor.
what
We
those
usually
blue?
use them for patients
Yeah,
that
I think Skechers have those too.
they can hurt a patient with Achilles tendonitis because when you first hit the ground, your heel kind of really drops down like that, which can exacerbate the pull on the Achilles, that rubber band on the back of your leg. So it'll really piss off an Achilles tendonitis patient. And then, but we usually use it for patients that have kind of like ankle fusions or big like ankle pain problems because it allows for just a little bit more of a natural gait And that's what happens when you have ankle pain. You just slow your gait really down. Your strides become really shortened. So it allows you to kind of just like a smooth kind of roll. I like that.
Do you
I think
do you
so,
ever
yeah.
recommend roller shoes in case
Yeah,
somebody
the
doesn't
light up
want
ones,
to
the
walk?
light up rollies. Yeah.
Are you talking about skates?
No,
Yes,
roller
just-
shoes.
The ones with like
Only
the
on
Heelys.
Saturdays,
Is
so I
that
can see
yeah?
them on Monday for their injury.
Yeah, the light up
Yeah.
ones, the ones with little skateboard
Exactly.
wheels.
Hoka actually has some pretty good
So that's more of a business
flops,
decision rather than a patient.
or sandals, other people call them. Hoka and UFOs, OOFOS. UFOs are good. Ben, that's another good one to add to your armamentarium for your foot conversations twice a day. And
Oh, I love UFOs. I love
yeah,
them.
Birkenstocks are in right now too. I love Birkenstocks. I never thought I would say that.
UFOs have nice clogs too.
Yes.
Oh.
Oh, they have colors and everything. Yes.
They are really in right now. My patients keep coming in showing me their Birkenstocks, and I'm like, aren't those old people's shoes? Apparently, they're not anymore. Yeah. Apparently, they're fancy.
Are there any other, let's say, you know, the Hokas or the UFOs, you know, you're not going to wear those probably out to a date night.
Yeah, I
Let's say,
gotcha.
you know, out here in Arizona when it's 117, you're probably going to wear sandals out to, I'm not going to say dressy, but you're not going to wear those, you know, out
The
to
ones that I
restaurants.
own?
Probably. You know, the brands
I
like
think- I
Rainbows or
think
something
that,
like that. What do you think about those sandals?
Most foot guys like it's
Me as well.
to me it's like I wanted to be a dentist for a long time for some reason, but it's like candy to me. It's like you're gonna eat it every now and then. It is what it is. I'm not gonna stop you, or beef jerky or pork rinds or however you want to think about it. But it's something that you are going to wear hopefully just every now and then and not all the time if you have a major foot problem. So if you don't have any foot problems, or you're like Matt and you're perfectly structured human, then you won't need perfectly accommodative sandals that support something. If a sandal's a sandal, now I don't love the Old Navy little foamy things. I think that's kind of a waste of time, but for the most part, you get what you pay for, right? And so I'm not gonna hold someone to the ground and watch them buy
goodness.
$200
Those are
sandals
horrible.
like Vionics or Fit Flops, or those are common brands of female sandals. I think they might have men's, but female sandals that have pretty little diamonds on them or whatever. And so they can be worn out to a dinner or not. But Vionics and Fit Flops are a good play on words there, but they are common. Dressier sandals, and the Birks. I got to throw the Birks in there. Good point. With sandals or without? What do you mean?
How about socks?
The slides,
Do you
right? The
recommend
slides.
socks. Like
Oh, we're getting
I like that
technical
question.
here. Yeah.
I,
I probably
Definitely
side with
without
or
sandals.
Sean
Yeah.
would probably side
That's a
with me
no-no.
on this one.
I know
and
that
I would
much.
say like compression socks, the Lycra socks are better than the cotton socks, and from a kind of vascular standpoint and trying to prevent a lot of edema or swelling in your legs, especially if you're a runner, especially if you're on your feet all day long working at the airport and you're standing for 12 hours. The non-cotton, to allow breathing, socks are going to be better, and they will allow for edema control. So, and CEP is a good brand. CEP. That was my attempt at sign language. CEP is a really good brand they make knee high and the sleeves and the smaller socks, and they have just colors and all the fun stuff. But they are, I would say, higher end. You're looking at them right now, Matt. They're probably $50 or something a pair. You get what you pay for. Yeah, they're pretty good. Really? Yeah. The white ones. Oh, okay.
I've never heard of those.
some are like 20. Those small ones.
I'm a Balaga fan myself.
you guys are nerds.
You've never lived until you've worn those socks.
Apparently, this is fantastic. I'm so excited.
Or Bombus. Hey, we'll take a shout out for Bombus.
My goodness.
Bumbus.
You wanna sponsor us?
There we go. This has been fantastic. I've learned a lot, and I think a good stuff to add to the toolbox and talking to my patients about
Like
their
physical
feet.
therapy.
I know. Apparently, I need to start doing that. Whoops. Dr. McAlister, unless Sean has anything else or Matt has anything else, is there anything that you kind of wish people would know about as far as feet goes?
Orthotics don't correct some things. That would be bunions, hammer toes. They don't correct. They're not Invisalign. They typically won't, even if you're 12 years old, they're not going to put your foot in a position and then all of a sudden you wear them for 3.275 years and then you take them off and your feet stay the same. It doesn't do that. They're not braces. They are, if the orthotics fail, typically that means either fail, meaning that they still have pain despite wearing an orthotic, then typically they need something higher up their leg. So meaning a AFO type of brace. What else? Generally speaking, orthoses and shoes and things are something that are often a kind of not a lead conversation. It's almost more of a flossing and toothpaste type of conversation. If I go back to the dentist thing, it's a maintenance conversation that allows patients. I have a shoe list. It's already done up, so I don't have to write it on a note thing every single time. It's such a common conversation. And so I have my plantar fasciitis one. I'll send it to you, Ben. I have my plantar fasciitis, my wide foot, my high arched foot. And it's very kind of dialed into patients' needs and desires. And so it's a common conversation. I'm kind of lead them towards the right type of shoe store that is one family owned like myself, but also going to give them the attention that I don't think is overburdening their pocket, but also is an educated conversation. So.
Yeah. What do you think? So I went to a running mechanics CEU course a couple of years ago, and they talked about how some of the arch problems that we have are caused by our reliance on the arch support in our shoes. Basically, the intrinsics weaken, and we cause our own problems by heavy cushion shoes. Where if you have a young kid, you don't let them wear these cushion shoes.
5 years ago, in that book,
may not have these problems. As
running,
they grow up.
what is it called again?
What do you think about that argument?
Run for Life, right. There was a book that came out that was some people went down to Mexico. They ran multiple ultra marathons. Actually, one of the authors went to my high school, and she ran cross country with me. But I think that generally speaking, that conversation has kind of died out a little bit. I think it was really hot 5-10 years ago when Vibrams were in, when more people were going barefoot and literally trying to run down the freaking street barefoot in socks or whatever. And I think that we wear shoes because we are in workplace environments because we want to have a cushioned walk that doesn't hurt when we're walking on rocks and pebbles or whatever, and we're not cavemen. And I don't think that we'll ever go back to that. I do think the mechanics of the foot can... I don't think that they will change so significantly because you wear a regular tennis shoe for a couple hours a day. I don't know if this has been perfectly studied in a person that's, a twin, and they set them down and said, "Hey, buddy, you're not going to wear shoes for a long time." I don't think they've ever done that. Exactly. You came out second, so you're not going to wear shoes for a long time. So I think it's just genetic. And
the twin concordance studies, yeah.
And because I see people that I think more the conversation would be like maybe what type of shoe. I do see patients with the problems that did wear high heels all their life, and that's usually the forefoot kind of problems, the toes and the bunions and stuff. And to me, the forefoot problems are shoes plus time plus genetics and equals bunion. But I don't think that we're going to someday like start not wearing shoes for life. That's just not going to happen. So I think those kind of CEUs are just kind of academic conversations. Yeah.
Yeah.
Right.
I appreciated that one, and I can't remember. I'm not going to.
One probably had really long hair.
I love that they had
was
three
like
presenters that had totally.
He was just wearing like a garb around his loins.
That was fun to hear.
Yeah. But yeah.
Oh, you've been to that one.
A loincloth, yes.
The other interesting conversation with that, I guess, that came out of it, and I don't have a question to follow this up on, but they were showing like they went to wherever it was in Africa that's produced like the top marathon runners over the past however many years, whoever won. You know, most of those marathons have been, I think the New York marathons have been from like a specific area, like a specific tribe, and they went there and videotaped the running patterns of them, but then they were shoeless their whole lives. And they saw like how their foot strikes, and they put a shoe on them, and they said go run the same way, and it changed their foot strike pattern immediately. They've never had it on before, so that's just another interesting conversation that came out of that.
I think that in that situation,
our shoes actually
that's why track shoes
are not that
like
we're going to go without them,
that's why there's nothing to attract shoes.
How our shoes actually changing?
Basically, they're like almost like a ballet slipper, but every shoe has that natural 7-degree drop that, yes, if they're already walking on their toes and then you put them in a 7-degree drop, it's gonna mess their strike up. But most of those people run on they have like a 4-foot strike anyway. So I don't know. It's an interesting academic conversation, and a lot of that in particular is just sports, not your everyday person that works at Fry's, that's overweight and has tight Achilles and diabetic and stuff. So,
yeah.
Hey, there we go. Doc Doc Goose. Yeah. Guys, thanks for having me, man. I appreciate it.
At least now we know if they have a tight Achilles, they go to physical therapy.
There it is. We've hit it.
Hey, thank you, Dr. McAlister.
Thank you.
If you want to follow him and his antics, he posts a lot on Instagram. He's at Dr. Jeff McAlister. That's McAlister spelled McAlister.
Thanks, guys.
And if you're in the Phoenix or Arizona area, you want to go be treated by him.
Yeah,
he's
no
the
problem,
founder
guys.
and owner
Anytime.
of Phoenix Foot and Ankle Institute.
Take care.
Yeah.
Thank you
Fantastic.
again for your time.
Dr. McAlister, fantastic having you on. Appreciate a lot of great information. Thank you. I'm excited. Thank you.
How are we going? Oh, to the fun part about sponsors. You know what?
Sponsors in the city.
These darn sponsors keep changing our codes.
God damn it.
Mostly because we have people out there that post coupon codes on websites. You know who you are. I'm the same way. If I want to find a coupon code for a random website I'm trying to buy something on, you know what? The people that lift those codes cause significant problems for the ones who those codes are associated with. And we're the ones that have that problem. So Groove Life keeps changing our codes because the code keeps getting lifted and used on their site over and over, which is great for revenue for us, not so much for giving discounts for them. So if you are going to buy those wonderful belts, which I wear my Groove Life belt every day. It is
every single day. I do too. And if I don't wear it, my pants fall down.
Oh,
Matt's got his on right now. Hey, I gave Matt some Groove Life belts for Christmas this year.
You did. They're amazing.
I love it. I love mine.
And there's silicone rings. That was their original one. Also, smart watch. I thought you were giving me a different finger.
No, that's the ring finger. Sorry.
They're bands for smartwatches. Go to their website, groovelife.com. Use the coupon code DDG podcast. Spell the whole thing out. DDG podcast. You're going to get 12% off. The other sponsor that I got to say, I got more people hooked on this last month, is Pros. Premium dietary products. I don't mean dietary that it's to lose weight. I mean dietary as it's healthy for you. That has CBD in it. Nods, their sleep aid, is absolutely phenomenal. I was telling Ben that my wife was having some rough nights sleeping, took the Nods, best night's sleep she's ever had for like several days straight, and now I can't get her to stop using it. So now I have to order double every month so that I have mine. It's just phenomenal. This stuff is not, it's not a sleep aid that makes you drowsy or anything like that. That's not how it works. It's made with a formula that actually gets you into deeper levels of sleep when you go to sleep. And how you notice that is you dream when you're in REM sleep. And I can tell you, I dream every night with this stuff. So I know I'm getting good sleep. Yeah, it's weird. I could have gone, before I started using this, I could have gone a year or two without really having a dream.
Yeah.
And now it's every single night.
Yeah. I never dream.
Okay. This is a case study. We're gonna get Matt a bottle of Nods.
I need to start dreaming.
Like in life, like you have dreams again, or like you dream while you're
dreaming
sleeping.
while I'm sleeping.
Are your dreams dead?
Lots of dreams in life.
So head over to Pros. There's a link on our website, our social media, get to it that way. Otherwise, you go to pros.com. That's spelled PROZE.com. Use coupon code DDG15. That's DDG15 for 15% off. Trust me, you won't regret it. Ben, have you ordered yours yet? You were doing the gum. You're doing their Yippies.
I was doing the Yippies. I love the gum, but I'll tell you, I forgot that we talked about this. I went home and did not dream because I did not take my Nods. I'm actually ordering some right now as we're talking. So
Don't forget to use the coupon code DDG15.
DDG15. Got it.
Other than that, you know what? I've really enjoyed doing this again. It's been way too long. We're going to try to do this again before 3 months goes by again.
Indeed.
We will.
We'll see if Matt can fit us into his busy schedule.
You're in.
Gents, it's been fun. It's bedtime. I got to go take my Nods.
I know.
So
right.
until next time,
Nice hats. Oh, sorry. Are we still on?
we're gonna we'll send you a hat, buddy.
Okay.
They are nice. We got to figure out when and how we're gonna give them away. So watch our Facebook and Instagram pages to figure out how you can get yours. It's coming. Until then, I'm Sean Palmer.
I'm Matt Irons.
And my watch battery's dying. I'm out of here.
Later.
All right.